Hello, thanks for taking your seats, and please come up to the front, fill all the seats, because otherwise people get sent up to a spillover room upstairs. So, welcome. I am Judi Kende. I lead Enterprise's New York market, and I am thrilled to see so many people who are interested in talking about health and housing for the afternoon. And we will be making the video of this available. I know many people had to narrow it down to one person from their firm, so people will be able to watch this. And I am thrilled to moderate this panel, looking forward, leveraging funding from the healthcare sector for housing as a preventative strategy. And I'd like to start by giving a little bit of the history, which is that over a century ago, the New York City affordable housing policy really began as a movement to improve public health. Today, poor neighborhoods continue to be the epicenter of our public health crisis, at the same time that we're facing a serious affordability crisis. So talking about health and housing isn't new. It's really coming full circle. However, there are certain differences. Today's public health problem isn't as visually galvanizing as Jacob Riis's photo exhibit on squalid living conditions in the tenements. Instead, it's very insidious, and it manifests in hospital emergency rooms and on heat maps correlating poor neighborhoods with high levels of obesity, heart disease, and asthma. On our last panel, we heard from folks from the housing sector and the community development sector about investing in healthcare. Today's panel, we have esteemed panelists from the healthcare sector who are talking about investing in housing. So I'm really pleased to introduce our panelists, Dr. Samuel Ross from Secours Hospital System in Baltimore, Jason Helgerson, Medicaid Director, State of New York, Department of Health, and Jenny Ismert, Vice President of Housing for United Healthcare. We're going to break this panel discussion into 3 sections, and we're going to try to keep our answers really brief so that there's time for many questions from the audience. The first section is going to be around best practice today and grounded in concrete examples. We're going to talk a little bit about barriers to the work, and then we're going to talk about our vision for the future and save about 15 minutes for Q&A. Our panelists' bios are in your packet, so I'm not going to go into any more detail about their backgrounds. So my first question is for Dr. Ross. Secours Hospital has been a community anchor since the 1990s, and as David made the CDC joke, for Dr. Ross, it really means both. So Secours Hospital not only understands the place in Atlanta thinking about disease control, but he also has his own community development corporation that has built hundreds of units of housing with tax credits. And the hospital has actually invested $2 million of its own capital into projects and put its balance sheet at risk through guarantees. So Dr. Ross, I'd love for you to describe a little bit about Secours' housing work, why you're doing it, and the results, both in terms of the number of housing units and the impact on health in your community.
Hey, thank you. A number of people are here from Baltimore. If you're from Baltimore or that area, raise your hand. Great. I have to choose which lies I'm going to tell. So she said be brief. I'm also, it doesn't say in my bio, I'm the son of a Baptist minister. So I will make 3 points and then pass the collection plate. So Secours, I'm actually a native Texan. Moved to Baltimore in 2006. I was at Parkland Health and Hospital System prior to that. And I'm a family physician by training. You remember Marcus Welby, the TV show? My original goal was to be the black Marcus Welby. But then got sidetracked into doing these kinds of things. I became familiar with community-oriented primary care, the COPC concept, when I was in Dallas. And then when I was recruited to Baltimore, they didn't call it COPC, but they did call it Building Healthy Communities. And what I saw was a health system in an urban area that really had committed to addressing the social determinants of health and really caring for people in non-traditional ways, providing health care. Someone rephrased social determinants to really say social contributors of health, because determinants means that kind of like there's no choice, but there are things that can make that different. So we are licensed for 77 beds in West Baltimore. And if you saw the unrest that occurred in Baltimore back in April, we were about 2 miles from where most of that happened. Those of us from Baltimore area know that CNN kept showing that same burning building for multiple days, but the rest of Baltimore pretty much looks like that on an average day. So, 77-bed hospital, we are actually developing, or we have developed over 700 housing units. And it started in the mid-90s with family housing, low-income family housing, which grew out of community prioritization efforts. And so Baltimore used to be a city of 1 million people, now a city of 650,000 or so, lots of vacant buildings. So the number one priority that came from those discussions with the community was their description of rats and trash. Rats and trash were a direct byproduct of those vacant buildings. So the first intervention that Secours did with the community was based on what the community said mattered most to them. And so from that, 119 low-income family units that are based on income and sliding scale. And then in addition to that, we have 6 low-income senior housing facilities and then have some disability patients or clients who live in those. We're currently engaged in a project with St. Agnes, which is another Catholic institution. There's a school where Babe Ruth played baseball in his early days, Cardinal Gibbons, that closed. And we're doing more market rate housing, again, with Enterprise. And there's some Enterprise people here. I think they're everywhere. But they've been our partner throughout this process, basically with the low-income tax credits. So we're continuing to build on that because we do see ourselves as that anchor, but more importantly, we see ourselves as the primary economic engine in West Baltimore, and that if we weren't doing it, there really is no one else who would be doing it. So it's been a system commitment, and the why, the why for us is it's the mission. Because if you looked at, when we looked at something recently that said, what makes a market desirable? And if you were a new company coming into Baltimore and looking to invest somewhere, there was no check mark on the positive side as to what would make West Baltimore market desirable, except for a mission and the culture that goes along with that. So that's our why.
Thank you. Jason, New York State has taken a leadership role in investing a portion of its Medicaid savings in affordable housing. Can you talk about how this initiative is working and any results?
Sure. Well, first off, I want to, for those of you not from New York, welcome. And I also want to thank the Federal Reserve Bank for, hosting this forum. I think it's particularly great that it's being hosted here on Wall Street. We need a lot of creativity to be brought to the table to help address some of the housing challenges that not only exist here in New York, but all across the country. So that's why I'm so pleased to be here. So in terms of housing and healthcare in New York, when Governor Cuomo took office in January 2011, he faced the worst budget deficit in state history. He was looking at about a $10 billion budgetary shortfall, and he also was looking at the largest Medicaid program in the country, and with an expenditure in north of $50 billion a year. That program was estimated to be growing, or would have grown year on year, by about 13%. Medicaid's about 35 to 40% of the total state budget. So in order to balance the budget, some pretty significant structural changes had to be enacted in the Medicaid program. And he created what was called a Medicaid redesign team to sort of develop a plan for how to reform the program. Out of that, we generated a discussion with our stakeholder community and with citizens all across the state of New York. We basically were asking folks for what they thought we should do to make the program more cost effective. And interestingly, as we traveled across the state, held public hearings, met with lots and lots of groups, and generated over 4,000 ideas out of that process. One idea that kept coming up over and over and over again, whether we were in the southern tier or whether we were in the North Country, whether we were in Buffalo or whether we were right here in New York City, the link between housing and healthcare kept coming up, particularly for our high needs Medicaid members, many of whom are in situations where they do not have access to stable and appropriate housing. So out of that effort, despite budgetary challenges, we set ourselves on a path to begin to reinvest Medicaid savings, and we've generated significant savings in the program over the last 4.5 years. We bent the cost curve. Our per recipient spending is now below 2002 levels. And with that, as we generated that savings, it's created opportunities to reinvest some of that savings into new initiatives. And one of the key areas we've invested in has been housing. We now spend $100 million a year of state funds in housing projects. Some of that money goes to capital. Some of that money goes to services. Some of that money goes directly into rents. The key thing about our program is that that is only funded with contributions from the state of New York. We do not have any federal match, which is typically the way Medicaid works. Is the state puts up $1 and then the federal government matches that, but we have not yet been able to convince our CMS colleagues to match those funds. But overall, we feel the program has been exceptionally successful. Right here in New York City, there are 4 buildings that are providing housing, congregate housing, that would not have existed if it were not for this program. We attempt to leverage our funds with other funds from other sources, and that's why I'm particularly interested in this group, because if we can bring more private capital to the table, there's more that we can do with our fixed pot of money. What I would also say is that, and I heard from the last panel, the need for data. And we are very sensitive to that. We feel that it's a part of our obligation is to track each and every one of the individuals who benefits from the various types of housing we provide, so that we can actually build a definitive case here in New York as to why this actually will lower total Medicaid expenditures, lower the cost of health care for the people that we serve. Because our dollars really target high needs Medicaid members who really need the housing to address their health care needs. And so we're tracking for each of our projects on a per recipient basis to provide hopefully a robust set of data pre and post that will show, so far at least, we've been able to help 5,500 individuals access housing in our 4 years of operation. So we're excited to help make that case, but we hopefully will build evidence, and eventually we hope to convince our federal colleagues to match our funds, which would allow us to turn our $100 million into $200 million. And I think if they are willing to cross that Rubicon with us, I think you'll see states all across the country stepping up, because I think at the end of the day, we can make this a win-win, not only for taxpayers, but also for the people that we serve.
Thank you. We're hoping that happens. We're going to ask you more about that. But first, Jenny, I wanted to hear a little bit about United Healthcare. You've been a real pioneer in seeing the linkages between health and housing. You've been investing tax credits in deals. You have been doing innovative work in Austin, and you have a new title, which I think many people don't associate with a health insurance company, which is VP of Housing. So tell us a little more about that.
Yeah, hopefully, I mean, just to quote a private conversation that you had, which was, why does United Healthcare have a VP of Housing? And so I think what we're seeing in kind of my position and what the work it is that we're doing is really largely looking at the impact of social determinants of health on the populations that we serve. So I work for a segment within United Healthcare called Community and State, which is focused on insurance solutions for the underinsured, low-income populations like Medicaid, dual special needs health plans. And so part of the work that we're doing is, and I think too, what we're seeing is an evolution with our state partners that are looking to bring in more medically complex populations into Medicaid managed care, and then also looking to provide incentives for managing social determinants of health. So we're seeing employment-related services coming in. We're seeing incentives structured around how it is that we better connect our members with housing, for example. And largely, these services and support sit outside of the Medicaid system, and we recognize that they greatly influence our ability to do what we're in the business of doing, which is providing the right care at the right time, in the right setting, and to keep individuals living as independently as possible for as long as possible. And our ability to housing is at the core of many of the challenges that we see when we're looking to serve highly specialized, medically complex populations. So within the business that we do Medicaid managed long-term services and supports, which is the waiver programs under Medicaid for the medically complex. I won't bore you too much. I could talk about waivers forever. It's a highly dry topic. But largely what it is that we're doing is trying to rebalance the system to put less of an emphasis on institutionalization and more of an emphasis on low-cost, community-based services and making access available to those services earlier on in the functional decline. I do think there's some barriers with that, which we'll get into later on during our discussion. But with some of the work that it is that we're trying to do around social determinants of health, my colleague down in Texas really kind of started this work internally, which is looking to, I think to the point that Jason raised about the data, we have a large population of our members that we cannot find. And so we suspect that those individuals are largely suffering from very complex social support needs in addition to being high utilizers of the healthcare system. So part of what we're trying to do is take our data, work with innovative, thought-provoking community-based organizations that are willing to look and see how we can share information to better support the work that we're doing and also better support the work that they're doing, because we largely are providing a lot of the services that are being funded for under Medicaid, like care coordination, community health worker support. We're largely coordinating the community-based supports that can wrap around an individual once you put them in housing and start to support the individual to maintain successful housing. So it's almost with the ACA and I think the deep penetration of the accountability in the system, we're starting to see this evolution and almost a recalibration of the system with services coming in under Medicaid. I think it's freeing up a lot of services in the community-based world. And then also part of what it is that we're wanting to do is take that work that started in Texas, evolve it into more deeply connecting our members to housing. How is it that we can expand the discussion around covering some of these services under Medicaid, pushing the policy discussion, piloting these issues to understand what exactly is the outcomes that we're seeing, similar to the work that Jason is doing, and then how is it that we can start to advance the discussion with our federal partners of how can we start to look at reinvesting healthcare cost savings back into the system? Can we start, as opposed to maybe looking at covering housing bricks and sticks, and look more towards covering rent as a healthcare intervention and studying what that means? So I know we're a little short on time. I'll stop there.
Dr. Ross, what do you think that the barriers are to other hospitals becoming a community anchors? Because you've done it so successfully, it hasn't been widely replicated.
Well, the biggest barrier is that people immediately jump to how is it going to get paid for? And if you start with that premise, then you won't do anything. We're Catholic healthcare and faith-based, and someone defined faith some time ago. It was an evangelist. He said, faith is faith in the face of the facts. So if you just took the facts that we all deal with, someone said it on the earlier panel, you'd say, why in the world would I do this? But Secours started down this path because they believed it was the right thing to do for the community. Now what's happening as enablers now, Maryland is a waiver state and has been, and about a year and a half ago went to what we call global budget revenue. Under global budget revenue, hospitals get a fixed cap, annual cap, and that was negotiated with the Health Services Cost Review Commission. The opportunity there is if you can control your cost, and some of the goals are about reducing readmissions and reducing ER utilization, reducing overall cost. If you can do that and you have savings under the cap, they don't dictate to you how you can use those funds. And so a lot of the efforts are about care coordination and we could reinvest in those wraparound services, because in addition to our housing, we do have another entity called Community Works, where we do workforce development, we do financial literacy, we have child care, and GED classes and teen parenting classes, and just a number of things that people need, because we found out a long time ago that it's not just enough to get you in the house. If you really don't understand how to stay there, if you really don't deal with a lot of the social issues, then people will continue to have these problems. So the barrier really is not having the will to do it, but being creative and innovative enough. And again, long before I got there, they started down this path, particularly in partnership with Enterprise. I don't want to sound like a marketing exercise for Enterprise, but everything we do has been with Enterprise as our primary partner, and their ability to do what they do on their side. And then every time we have a ribbon cutting, there's just a whole list of people, who have been partners from the city, from the state, from foundations and others that have allowed us to do this. And so I think if we continue to focus on not the barriers, but the enablers, that some we've heard about today and others that we'll continue to talk about, that we'll find ways to continue to expand upon this. And I'll say one other thing that's happening in Maryland. Under the global budget, all of the hospitals are beginning to realize that if they're going to achieve the goals, the metrics, that if they don't do these types of things that we've been doing now for 20 plus years, then the state as a whole will not be successful, and we might lose the waiver as a result of that.
Thank you. Jason, you provided the perfect segue to my next question, which was that you said that what's preventing New York and other states from doing more is having the Fed actually contribute their half of it. And so how do we do that? What's needed to make that possible?
Sure. So, we, like Maryland, about a year and a half ago, successfully negotiated a waiver to do delivery system reform. In our original proposal, we had a pretty significant ask to the federal government relative to investments in housing, particularly supportive housing, targeting our high-needs Medicaid members. And CMS at that time was not prepared to fund our proposal. The overall plan was adopted. And while we continue to move forward with other changes in the delivery system, we're still sort of underfunded in terms of what we have in terms of resources on the housing side. That said, I think we just have to continue to make the case. But I think one thing, and as was mentioned, the move to value-based payments, which is a fundamental change in how healthcare is purchased, that is ongoing, and you're starting to see it happen all across the country, is potentially an exciting opportunity to tap into a reservoir of potential financing for housing. When the providers all of a sudden, instead of having incentive to provide more levels of care, more emergency room visits, more inpatient stays, and you reverse that incentive, and now the incentive is really to try to keep people healthy in the community and out of the hospital and institutional settings, now all of a sudden housing solutions become a lot more attractive. I think we need to find a way to tap into that. And I would say why that links back to your question about the federal government is the federal government has said very clearly, and Secretary Burwell has made her top priority the move to value-based payments within Medicare, and to support states in the move to value-based payments in Medicaid. And so we're moving very aggressively. We have a goal at the end of the 5 years, actually it's a requirement for us now, that 80% of all reimbursement to providers is value-based. So that potentially sets up a stage for us to build off what we have, but I think at the end of the day, we're potentially going to prepare a specific ask to get more federal financing into this, and I'm hopeful that as time goes on, as we can make the case with